Ladies and gentlemen, good afternoon and welcome to our second webinar session dedicated today to end osteoarthritis. My name is Ingrid Crevoiserat and I'm the Administrative Director at Swiss Medical Ghent. Before giving the floor to the doctor, I will shortly present you Swiss Medical Ghent, and on the other side, Olga, our interpreter of the day, will simultaneously translate the presentation in Russian for the Russian room. Meanwhile, we speak in English to you. Just to let you know, we are an independent international medical coordination structure whose general manager has been in the medical field for about 20 years almost. We are accredited by most of the hospital, university hospital in Switzerland, private clinics, doctors, professors, and world-renowned doctors. We'd like to draw your attention in case you don't know. Most of the doctors in Switzerland are independent, which means they are not employed by a clinic, but accredited by them. It means that they have the choice to operate the patient wherever they like. And this is exactly what we are looking for the patient. We are looking for the best specialist in the clinic of his choice. We always search for the best practitioner because this is what is important for Swiss Medical Ghent. Due to the fact that we have a multilingual case manager team, they will be able to respond to your demand within 48 hours, and they will be accompanying the patient throughout their medical stay. We will proceed to your demand with the best specialist. We will send you the relevant code, and if you accept it, we take care of the administrative aspect. By that, we mean all the things regarding the visa, the hotel, the transfer, coaching, anything like this related to the administrative side is taken care of by Swiss Medical Ghent. The patient himself will be taken care of by the case manager, will take care of him from his arrival until his departure at home. And we also take care of the medical follow-up after his return at home. If necessary, you can always refer to us if you need an interpreter, because they are accredited by our structure and they facilitate the ease of the patient's stay. He doesn't have to worry about that. But in case that it will be ordered meanwhile he is here, we can afford it as well, not a problem. Our goal is to satisfy you, but above all, we are listening to the patient needs, and we request, make him our main priority is the patient's request. This is actually the main reason of our slogan, patient first. Sorry. Coming back to the webinar, and according to the choice, you know that you are most than welcome to ask any of your questions at the end of the presentation of the doctor. Please feel free to do so. And I will just ask you for a small request for the smooth running of the webinar. Please, if you can, switch off your video and switch off your microphone. I will leave now the hand over to our medical moderator, Dr. Michael Rabaeus, and I wish you a pleasant webinar.
Thank you, Ingrid. I'm very happy to be here with you all, and especially for this very interesting subject on the new techniques and treatments for osteoarthritis of the hands, which are an extremely unpleasant ailment when it happens to us. And my friend Grégoire, who will be giving us this presentation, is very clearly one of the best surgeons I know for this, and I have several patients that have been remarkably improved by his interventions. So it's really a pleasure to hand over the hand and the floor to Grégoire so that she can show us what is possibly to done. And then we will answer the questions afterwards. Your turn, Grégoire.
Okay, good afternoon, everybody. I'd like to thank everybody for attending this meeting on hand surgery and specifically on osteoarthritis, which is a main problem and the topic will be split into two parts. One is just to explain what is the osteoarthritis, and the second part is what solution we have, whatever the location of the osteoarthritis. So the osteoarthritis is into the joint when you lose cartilage just into the joint. So it may lead to discomfort, pain, deformities, and finally the functional use of the hand may be compromised by the osteoarthritis. Mainly the osteoarthritis is a primary osteoarthritis. It means it's degenerative. But you can have osteoarthritis due to microcrystal arthropathies such as the gut or as the chondrocalcinosis, which may destroy the joint, or it could be following a trauma when the injury impacts the joint with an articular fracture. So for the degenerative osteoarthritis, it can concern mainly the distal part of the finger. You can see here the joint at that level, or the base of the thumb. It's frequent, and it's mainly female in 67% of the cases, and only 20% are symptomatic. I just want to first focus on one thing, is that there is no radioclinical parallelism. It means that you can have a big destruction on the X-ray and have no pain. And in the opposite, you can have just a small destruction and have a lot of pain. So what we can treat is the pain. And it's the clinical examination is fundamental for this point. There are some etiology factors for this type of osteoarthritis. It's the age, female in 80% of the cases, obesity, tobacco, hormone deficits, joint overuse, or repetitive microtrauma. There is maybe a genetic predisposition for the distal IP joint, just close to the nail. And the topographic repartition, we saw that it was the distal part of the fingers and the base of the thumb. Concerning the secondary osteoarthritis, it's the destruction of the joint by the precipitation of microcrystal into the joint, such as the gut, or as you can see the gut here, you have soft tissue around the joint, which is full of deposit of microcalcification, and then it may lead to destruction of the joint. So you have secondary osteoarthritis. For the chondrocalcinosis, it's exactly the same, but it's instead of deposit of uric acid, you have calcium into the joint. And there are specific locations for this type of deposit, which is the base of the thumb, the STT joint between the scaphoid, as you can see here, the trapezium and the trapezoid, just at that level. It can destroy the scapholunate joint. The scapholunate joint is just right there between the scaphoid and the lunate. And then, due to the destruction of the ligament, you can have a collapse of the bone and then osteoarthritis. This type of lesion can concern the TFCC, which is the ligament just close to the ulnar side of the wrist, right there. It's just deposit. But you can have deposit also in the knee or in the shoulder, as you can see here, the double line, which means that there are some calcifications just around the joint. So concerning the hand surgery, it's specifically the STT joint, as you can see here on the picture, the scapholunate joint, just at that level, and sometimes you have combined osteoarthritis, which may concern the metacarpal joint and the trapezium. The origin of a secondary osteoarthritis may be an inflamed arthritis, such as the rheumatoid arthritis. We don't see any more rheumatoid arthritis due to the effect of immunosuppressors, which are very effective. But sometimes with old patients, you can have destruction of the joint, but the primary lesion is the synovitis. Be disgusting, but you can see here the synovitis. So it's the tendon sheath which is inflamed to the disease, and then it destroys the joint. You can have tendon rupture, you can have a lesion at the metacarpal joint, or destruction or collapse of the wrist. But finally, the osteoarthritis is just the consequences of the inflamed synovitis. And post-traumatic, it means when you have a destruction of the joint or an intra-articular fracture of a distal part of a joint, the cartilage is not healing. Even if you do correction, which seems correct, the line that you can see here is definitive, and there is no healing of the cartilage. It means that later, you can have osteoarthritis when it concerns all the joint. So for an athlete, for example, most of the time the lesions...
Я уже так внимательно слушаю about destruction.
Давай.
Так, оставляйте вот эти вот доктор, собака, сокрута.
А что оставлять?
Владимир, вы выключите звук, вы мешаете...
Ой, извините, я входил без звука. Простите.
So you can have, it could be, osteoarthritis could be the consequences of a lesion of a ligament which is neglected by the athlete at the beginning of his career. And later when he gets older, you can have osteoarthritis because the ligament is not safe, and then you have constraints on the bone and you can lose cartilage. But here is an example of a scaphoid fracture. You can see it on the left side, just right there. It was not treated because it was not really painful. And 30 years later, you have a humpback deformity of the scaphoid, a non-union, and it leads directly 30 years later to osteoarthritis. It means that it's a carpal collapse with cartilage defect on the radiocarpal joint and on the midcarpal joint. So, and for the fingers, it's the same. You can see here an old athlete, a cricket player, and he got deformities of the finger because he neglected his injury at the beginning because it's just finger. So he can continue to play. But later, the destruction of the joint may lead to osteoarthritis. So you lose the cartilage. So finally, when we try to sum up this sequence concerning the osteoarthritis, it's mainly primary osteoarthritis, and it concerns female under 50 years old. But you can have the consequence of the destruction of the joint by an inflamed rheumatism or post-traumatic. So we are going to try to make a sort of a leaflet of what type of injury we can have or what kind of lesion, depending on the location, and what type of treatment we can propose. At the wrist, you can see here a wrist, but there is no more cartilage on the first row here, in between the first row and the radius. So it may lead to destruction of the cartilage. So the wrist is stiff, is painful. And in that case, when all the cartilage is concerned at every level, the only option when we failed with conservative treatment, which is splinting or corticoid shot, And if the pain is increasing and you have a real discomfort by using your wrist, in that case, the only solution is to fix the bone by using a plate, for example, but it's definitive. You have no more motion in flexion, extension in your wrist. But it's a way to treat by bone fusion the osteoarthritis. The alternative treatment is to use prosthesis. Prosthesis is, there are new models, so it's innovating surgery. It's a model coming from Sweden. You see, you have two parts. One is a stem that it introduced into the third metacarpal, and the other stem is introduced into the radius. And then you have a link between both to be able to move the wrist in flexion, extension. So you restore a pain-free wrist with conservative full range of motion, and it's stable. As you can see here on the picture, it's during surgery. So we test the prosthesis with models, and you see that it's stable. And after this, 6 weeks later, when you see the patient, you can see that he has a full pain-free range of motion without trouble, finally. Here is a picture during the surgery, just to show you when it moves laterally during the X-ray. And here you have the same when the patient is moving the wrist. And in flexion extension, say it's the same. When you bend the wrist and you extend the wrist, you have full motion. So, in that case, the lady has full motion of the wrist, she is pain-free, and the osteoarthritis is treated by a prosthesis. The osteoarthritis could concern the joint between the radius and the ulna. So in that case, usually we perform this type of operation. We fix the distal ulna with the radius using a screw, and we perform an osteotomy just up the screwing just to be able to move in rotation. But there are some models for prosthetic. Here you can see the replacement of the joint by a prosthesis. The survival rate of this type of prosthesis, such as the previous one, is approximately 90% at 15 years of follow-up. It's modular prosthesis. It means that if one piece is damaged, you can change it. Concerning the corpus, so you have 2 rows of bone, scaphoid, lunate, and triquetrum, and here the second row. Main of the time, the lesion is post-traumatic. It means
Je vais vous écrire un petit mot maintenant, d'accord? Parce qu'il faudra faire aussi évidemment une lettre de support, comme quoi cette dame vient pour vous.
Marina, on t'entend.
So you have a lesion here on at the level of the scapholunate joint. You can see here the lunate and the scaphoid. So the ligament is disrupted. If you don't treat it, later the scaphoid is going to migrate into the radius and to osteoarthritis at that level. So most of the time, corpus osteoarthritis is due to post-traumatic change. We have different options to treat. It depends how is the cartilage on the second row. But you can perform a 4-corner fusion, which means that you fuse all the bones together and you create a new joint between the lunate and the radius. You have the picture here with, it's different. So the advantages is that it's pain-free, you restore the strength, but you have a small range of motion of the wrist. You can expect 20 degrees of flexion and 10 degrees in extension. The alternative treatment is to remove these 3 bones, such as in this case, and to create a joint between the capitatum and the radius. In that case, you conserve the range of motion, but you lose the strength. You can expect 1/3 of the opposite side. When the joint is destroyed at that level, following the disruption of the ligament, in that case, the 4-corner fusion or the first row resection is not possible because you have no joint in front. So the only possibility in this case is to perform a total fusion of the wrist, as we saw before, or a prosthesis. The prosthesis, the aim is to restore the range of motion pain-free and to restore the strength. Now, when we go down into the wrist, you have the STT joint. We saw previously that most of the time it's due to chondrocalcinosis, and it may lead to deformity on the wrist at that level. And the evolution is that when you have precipitation of the microcrystals into the joint, it's painful, it's swollen, and the range of motion is limited. Specifically when you want to take something in between your 2 fingers. You can see here a normal joint at the trapeziometacarpal joint at that level. And here you have no more motion because it's nearly fused. But the micro mobility of this joint is painful. So what we have after failed conservative treatment, I mean, when you put a splint at night, for example, to have less pain, a corticoid shot may be advised. But if the pain continues to increase, there are different options. One is to fuse the 2 bones, the trapezium and the trapezoid, with the scaphoid. So it's a bone fusion. But the problem with this type of operation is that you limit the flexion and the extension of the wrist. So we don't use it anymore. The distal pole resection is you just remove the distal part of the scaphoid. But the problem is that if you do this, you can have a collapse because this ligament, we are never sure that it's safe in the case of chondrocalcinosis. So the best solution is to put a spacer in pyrocarbon, which is a small disc that we put in between the joint. I will show you the spacer. It's like this. It's 1 franc, like a coin, and you have a dorsal approach, and you replace the distal part of the scaphoid by this implant. So you restore the length, so the strength, and its pain-free wrist. You can see here the images of the spacer, which is placed in between the trapezium and the scaphoid. You can use different type of pyrocarbon. This one is normally used for this joint, and we can place it here. And in that case, we don't need to remove the distal part of the scaphoid, but we change just the roof of the trapezium to be adapted to the prosthesis, as you can see here. So it's a small surgical approach. Now we're going to speak about a common problem, which is the osteoarthritis at the base of the thumb, which concern female under 50 years old in 80% of the cases. It's a deformity of the base of the thumb with a first web retraction, which may lead to weakness when you try to twist a key or to open a bottle. So it concerns the joint between the trapezium and the first metacarpal. So you have the deformity, you have the pain, and specifically the weakness. If we perform an X-ray to everybody under, I would say, 70 years old, everybody has osteoarthritis, but it's not painful. It's only 20% of the osteoarthritis of the base of the thumb which is painful. And this is the main concern for the treatment. Here, you can see it's this joint which is concerned. You see the metacarpal is impact into the trapezium. So when you move, the cartilage defect and the osteoarthritis is painful. Here you have a stage which is more important with nearly a fusion. But when it's nearly fused, finally, you have no more pain. So the treatment is not to treat an X-ray. We have to treat a patient. So we try first a conservative treatment by splinting, injection, and if we fail, so it's 20% of the cases, surgery may be indicated in case of persistent pain, decreased function, and after failure of the conservative treatment. The usual treatment is to remove this bone. If you remove the trapezium with a ligamentoplasty, you have no more contact between the first metacarpal and the trapezium. So you have no more pain. But the shortening of the thumb may lead to, you lose your strength. So you have no more pinch, the strength specifically to take something by using the index and the thumb degrees. And in addition, you can have an impaction. You see that the space here is, after a while, it's decreasing. So you can have an impact between the first metacarpal and the trapezium. That's why treatment, now we are using prosthesis. It's such a hip prosthesis. The aim is to restore the length of the thumb and to restore the strength by just restoring the length of the thumb and full range of motion, as you can see. So there is no physiotherapy which is needed, and you have a better opposition with the thumb when you compare it to the trapeziectomy. You have a dorsal extension. It means you can lift up your thumb without pain at that level. And the key pinch, of course, is improving. For example, if you have 5 kilos for the strength, after this type of surgery, you can have 10 kilos of strength. You correct the Z deformity by restoring the length, so all around your thumb, and the aesthetic appearance is better. So we use different type of prosthesis. Now we use the double mobility. It's a stem, such as the hip surgery, a neck, and a cup. And you have a double mobility into the cup here to avoid any dislocation or unsealing of the prosthesis. Surgical approach, I will be quick. It could be dorsal, which is mainly the case, or lateral. It's a small incision of 2 centimeters, and then you implant the prosthesis, you control with X-ray. And after this type of surgery, this is the appearance on the X-ray. You have the cup, the neck, the stem. We don't use cement, it's cementless prosthesis. So you have to wait for complete integration of the prosthesis 6 weeks. But you have immediate rehab. I mean, you can move your thumb immediately after the surgery. This is an example of a lady. She was 40 years old, so she was a young lady with a major osteoarthritis of the base of both thumbs, and we perform prosthesis on both sides. And she was a motorbike rider, and she returned to motorbike 6 weeks after the second operation. So to tell you that this type of prosthesis is probably one of the most improvement in hand surgery to restore a pain-free thumb and the strength of the thumb. Sometimes it could be combined with an osteoarthritis at the base of the thumb here, as we saw previously, and on the STT joint. In that case, you have two options. So this is an example with restriction of the metacarpal joint. You can see that the Z deformity of the thumb, and the joint here is compromised by the osteoarthritis. So the treatment is, you can remove the trapezium like this, so you have no more contact on both sides. But the problem is the shortening of the thumb. The alternative treatment is to combine a prosthesis on the trapeziometacarpal joint and a spacer, as we saw previously. So it's a double prosthesis to restore the length of the thumb and the strength. Here is another example. And the patient is finally happy with this type of surgery because he can return to his normal occupation. The prosthesis can be input when you have no more first row. As you can see here, the first row has been removed because there was osteoarthritis in a case of slack wrist, as we saw previously. We remove the first row, and in the same time, we perform the prosthesis. So you have nothing. It's sort of, it's a free thumb, but it's working too. It's not going to displace. Now I'm going to talk about long fingers. And long fingers, it means there are three joints: the metacarpophalangeal joint, the PIP joint, and the PID joint, the distal interphalangeal joint at that level. So in case of osteoarthritis, every joint can be concerned. You can see here there is a destruction of the distal joint and deformity with fingers with clinodactyly. It means that it's moving laterally and it's difficult to take something with the opposition of your thumb. It's the same, we have to have the same way of thinking. Just do surgery when it's painful. When it's not painful, conservative treatment is enough, just by corticoid shot or splinting. The problem of long fingers, they need to have full motion. They have to be flexible. When you bend a finger, you have 60% in the joint here for the flexion, 30% in this joint, and only 5% in this joint. It means that if you have osteoarthritis and you have no more motion and painful joint, in this joint, the treatment is to restore the mobility. So by using prosthesis, never fuse this joint. In opposition, you can fuse this joint because it's only 5% of the mobility of all the finger. So the best option when it concerns the distal part of the finger is to fuse the joint, we will see later. And for this joint is to use prosthesis to conserve the range of motion of the finger. If the finger is stiff after fusion, you're not going to use it, and it's going to exclude finger. So for the MCP joint, so at that level, you can see here there is no more cartilage for this finger. If you resect just the joint as it was in the past, you have a shortening of the finger, which is very small finger finally. I don't know if you see, but the finger is really shortening. So it's not a good option. We replace the joint by using elastic prosthesis. It's like an elastic, you put it into the joint, so to restore the range of motion and to have less contact or no more contact between the two pieces of bone. So to replace the damaged cartilage. You have you can see here the prosthesis in place. We use a saw etc. And we put the prosthesis just in, you can do it for several fingers in the same time to restore a full motion. And you don't need to splint after this type of operation the fingers, and immediate motion is recommended with a physio practice. Here you have an example with a surgical approach on the dorsal side here to replace all the joint which was damaged by using silastic prosthesis. You can see a metallic piece we call it grumettes. It's just to see that there is no migration of the prosthesis later. But inside the hand, it's like this. For the PIP joint, it's quite a little bit different. It could be post-traumatic because the joint was damaged due to surgery and the trauma. And then you have no more cartilage, or it could be degenerative osteoarthritis. So it may lead to a swollen joint with less motion and painful. And there is no contact between the pulp and the palmar crease. And the fingers are like this, and you can't bend anymore, so you can have strength. So treatment is, if you want to treat just the pain, an option is what we call denervation. It means that we remove all the nerves into the joint, not superficial, but inside the joint to have less pain. But the osteoarthritis continue to evolve naturally. You can put prosthesis with two different types of prosthesis. I will tell you later. Or you can fuse the joint only if it's the index finger. Because if you fuse the other finger, it's going to be an exclude finger. For the index, it could be an option, specifically if you failed with a prosthesis to fuse it, as you can see here. But the flexion is, you have to put the flexion of 80 degrees to keep it in opposition with the palmar crease. So it means that in extension, your finger is bended. So for the treatment, we can use prosthesis. For the prosthetic arthroplasty, we can use silastic prosthesis as we did for the MCP joint. So it was for the MCP, but you can use it here. This type of prosthesis is no more using because it's dislocated prosthesis. The alternative treatment is this type of gliding prosthesis, which gives good results. So you can see here the Swanson prosthesis at the PIP joint. You can see in the profile, in the strict lateral view, you can see the prosthesis and the result by bending this joint. You have nearly full extension and you have a flexion of 90 degrees, as you can see here. The main trouble with this type of prosthesis is that you can have destruction, as you can see here, with the prosthesis which is not in place because the stem was broken after the surgery after a while. This type of prosthesis is new. It has 2 or 5 years old of follow-up, and results seems to be interesting. You can see here the picture of the prosthesis with the polyethylene into the joint and full motion of the finger. So it's an alternative treatment to silastic. We need probably a little bit more of follow-up to be sure that it's a good option at that level. Concerning the distal joints, you can have nail deformity due to proximity of the osteoarthritis with the matrix of the nail. You can have deformity of the finger with lateral deviation, or in this way, and a lack of extension of the finger and a painful with osteophytes. It means with bone constricted around the joint, which limited the motion. Here you have a few examples. You see this patient with the finger which is not in front. So we can correct if it's painful by bone fusion. It's probably the best treatment because When you use small prosthesis, it's unstable. So we recommend not to use the prosthesis at that level, but to fix the distal joint. And with different angulation of fixation depending of the finger. For the index, you need 10 degrees of flexion, but for the fifth finger, you need to be in a position with the pulp of the thumb, you need 35 or 40 degrees of flexion. There are different ways to fix this joint, as you can see with key wires or using a screw. But the problem when you use a screw, the extension will be straight because it's into the canal you put the screw. So if you want to conserve a flexion, key wires are much more advised. The problem is the contact with the pulp because you have to keep a splint for 3 months, time for bone fusion. The alternative treatment, which is innovating, is using this type of stemple, which is you put it on a dorsal approach of the finger, you have different angulation, and you don't have the key wires into the pulp. So you just fix it, and the stemple is going to open during the surgery to have compression of your distal joint bone. Sometimes it could be necessary to correct an aesthetic deformity of the finger. It's a demand of women when they have, a deformity of the distal joint. But to be honest, when you remove the osteophytes, the bone, the main problem is that you have an increase of the osteoarthritis. You don't treat the cause, and you have relapse. After removal of the bone, you have the finger looks correct, but it could be painful and you can have relapse. That's why this type of surgery must be, you have a balance to discuss with the patient. But most of the time when you fix the joint, it's definitive, and in that case, you are pain-free and you have no relapse. And sometimes you can have, when it's the distal part of the finger, you can have ganglion cyst on the dorsal side of the finger. It's a sort of hernia coming from the hyperpressure of the joint into the osteoarthritis. In that case, if the joint is mobile and it's not painful, you can have just a soft tissue treatment, which means to remove the cyst, to clean up the joint, and to replace the skin by a skin graft. You take it from the wrist to cover the distal part of the finger. And in that case, you have a complete correction of the ganglion cyst. But if the osteoarthritis is still present, but if it's not painful, it could be interesting to treat the lesion like this. I think I have finished. I wanted to thank you very much. And if you have any question, just to sum up clearly the new indications, is to use prosthesis with a survival rate which is different depending on the type of prosthesis, but it's probably an evolution which is this type of surgery could be done with local, regional anesthetic. You don't need to have a total, and you restore a function for a finger or for the wrist, and you restore the function, so the ability to use your finger or your wrist. Thank you very much.
Thank you, Grégoire, very much for this very interesting presentation. I must say I was quite impressed by the numerous possibilities that I totally ignored their existence personally on all these different type of prostheses that you can use in the fingers. And I also draw the conclusion from that it's very important that we do have surgeons like you who are extremely familiar with all these things and know how to choose. And indeed that one should always, when it's possible, one tries not to operate, because that's something that can also work. So that was, in my opinion, very interesting. I don't know if we have any questions. I haven't seen any. Nope, as a participant. No, apparently we don't have any questions.
You can, don't hesitate to. I don't know if you can go directly through the video, but it's.
There's a question coming, but it's in Cyrillic, so Alex will translate it for me. Ou Marina, tu peux me dire ce qui est marqué?
Non, Marina ne peut pas parce qu'elle a eu une urgence, donc c'est Alex qui va le faire. So I'm just reminding everyone that actually you can either write your question, but you can also give them in orally to the doctor. So do not hesitate to pick up the words with him if you like so. We will go through it quickly because I suppose that some of you are to go back to work as well. It was a very interesting presentation. I'm sure that all of you learn. On my side, I did learn a lot, as you said before, Dr. Rabaeus. So meanwhile, Alex is getting back to us with the translation. We may have other questions.
We have one first question here. How long is the rehabilitation after operations?
So it depends of the. It depends finally of the joint which is concerned, but the aim of the prosthesis is to have the motion. So we start immediately the motion of the fingers. Rehab, it depends. Finally, you need a few sessions of rehab for the long fingers to conserve what you get during the surgery. So you have to move immediately. This is the aim of a prosthesis. But sometimes you have to take care, and it has to be made under the supervision of a physiotherapist, because we don't use any cement to fix the prosthesis. So the motion of a wrist, for example, you have to wait for the osteointegration of the prosthesis by your own bone. So it's hydroxyapatitis which cover the prosthesis, and it is rehab by the own bone. So it takes 6 weeks. But if you fix during 6 weeks your prosthesis, you're going to be stiff. So you start moving your wrist under the supervision with the physiotherapist. And after 6 weeks, there is no limit for using the wrist. So the rehab depends of the type and the location of the prosthesis. For the thumb, you don't need any physio. You have exercises to do to be able, after a few days, to put your thumb like this and to have full extension.
There are two other questions. One is, are there often aseptic necrosis of the bones after such operations?
No. So the problem of in the case of prosthesis, you have the one which is in silastic, as we saw for the MCP joint, for the long finger, you know, the elastic, silastic prosthesis. The main problem is that you can have constraint on the prosthesis and you can break it, or you can have reaction. We call it silicosis. So it means it's the destruction of the bone around the prosthesis, such as we observe in the lupus. It's similar. So, or in the prosthesis, for the breast prosthesis. So it could be, it's maybe 2 or 3% of the cases, but you can have a destruction of the bone around the prosthesis in case of silicosis. For the other prosthesis, the risk is the unsealing of the prosthesis when you have micromobility around the prosthesis. And it's specifically for this type of prosthesis, it concerns only the cup here. And it's only 2 or 3% at 5 years of follow-up. So it's very rare, but it's possible.
And then last question, is there an age limit?
No, there is no age limit. I mean, for example, if you have osteoarthritis for an athlete, because he had an articular fracture, it's very difficult to treat, of course. You're not going to put a prosthesis to an athlete. Because his career is done. So we have to treat him by what is possible off season and to try to wait when he retired. And when after his career, so maybe at 40 years old, if you want a limit, it's possible to treat by prosthesis from 40 years old in case of an athlete. But it's mainly the pain and the destruction of the joint. So you can perform this type of surgery even at 80 or 90 years old. If you have a patient which is very painful, he can't use his thumb, he can't use his finger, it's for his autonomy, it could be really an improvement. Maybe if you have 5 or 6 years to live, it's for the discomfort of the pain, it could be a solution. So there is no limit in age. I mean, at 90, you can have mentally totally ready for this type of surgery. So it's much more the comorbidity which has to be discussed. But it's possible to do this type of surgery in older people or young.
There is also a last one here. Natalia Smirnov is asking, is there a complete hand prosthesis? Is that possible?
The aim of the prosthesis is to replace a joint. So you can have affected bone at different level. You can have the fingers, but it could be combined with the thumb. It could be combined with the wrist. So as we saw, we can replace different joints in the same time or in different times. It depends which type of joint is concerned. But
I believe the question was more that the whole hand, the full hand. I mean, to replace from the wrist and down.
No, it's not. You're not going to replace a full hand, but the people conserve the sensation. I mean, if it has no trouble with the sensitivity, with the nerves, you're not going to replace all the fingers by prosthesis. I mean, it's cosmetic prosthesis. For the function is there are some models, but you replace the hand when you have a complete amputation, not because you have osteoarthritis.
Okay. Well, I believe that was all. That were all the questions. So, Grégoire, once more, I really thank you very, very much for this comprehensive and extremely interesting presentation. And thank you all for joining us. It was a pleasure to have you with us. And looking forward to our next meeting, and I'll turn back the word to Ingrid.
Thank you, Dr. Rabaeus.
I can say I just want to say a word. I didn't thank everybody and the team and Marina for attending this meeting, and it was I was really pleased to do it. So thank you very much to you.
Thank you, Dr. Schick. It was an interesting presentation. I'm sure that we all learned a lot about end surgery. I would like to inform you that our next webinar will be on the 20th of May. We will present you a small clinic in area in between Geneva and Lausanne who should be presenting their oncological department. So we're looking forward to that next session. And until then, we thank you once again for all of you for your participation. Thank you for Dr. Schick. Thank you, Dr. Rabaeus. Thanks to everyone. And we wish you a pleasant rest of the day. Thank you very much and see you soon. Bye.
Thank you. Bye.
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 Salut Grégoire.
Salut.